Well, I would request Dr. Naomi Ten to please give her keynote address on the topic of prevalence of the ocular and visual abnormalities following symptomatic and asymptomatic congenital CMV infections. Dr. Naomi, please.
Oh, the other one. Sorry,
Just a second. So, I would request Dr. Dhol to please chair the session and come forward, and Dr. Rohan Cheriwal also. Please join on the dais.
Is there a pointer? Maybe not. Okay, good morning. So this talk is about the prevalence of ocular and visual abnormalities following symptomatic and asymptomatic CMV infection. And it has been a systematic review and meta-analysis. Thank you. So these are my co-authors you see at the top here. And this study was run by Lola Salibo at Great Ormond Street Hospital in London. So in context, congenital CMV is the most common congenital infection. It affects 1 to 2% of live births worldwide, and we know that there is a higher rate in lower income countries. Congenital CMV is recognized as a cause of visual disability. So in this work, we looked to divide congenital CMV into patients who have symptomatic CMV and those who are asymptomatic. So just a reminder here of the features of symptomatic CMV. And this is a European consensus guideline, which was published in 2017. And you can see here the features the neonate may have to be diagnosed with congenital symptomatic CMV. And that includes particularly hearing loss, but other systematic comorbidities, several of which you can see have potential to be visually disabling. So around 1 in... So the analysis was targeted at looking at visual impairment and structural disorder as separate, aiming to get a separate pooled prevalence for each. And those pooled prevalence measures were assessed for bias, heterogeneity, their sensitivity, and confidence levels in the pooled prevalence. The data were then sub-analysed, looking particularly pre and post that quite landmark European diagnostic criteria being introduced in 2017. And they were sub-analysed for study design, follow-up time, study population, because some of them were particularly looking at hearing populations versus the whole population. Some of them particularly were looking at premature birth, and we also looked at what level of income the country from which the paper originated. So, of the 12 studies included, this included 1,100 asymptomatic children and 780 symptomatic children. All of those papers came from high or middle income countries. There was a really variable preterm birth, normal being about 10%, so it was quite varied. And the median follow-up, again, very varied, from 35 to 156 months from diagnosis. So this is really what we were aiming to see. So these are the pooled prevalences. So we looked, again, at asymptomatic and symptomatic patients for evidence of visual impairment and ocular disorder. So if we first look at the asymptomatic column, the pooled prevalence suggests a level of less than 1% visual impairment in children who have no other symptoms of CMV systemically. And similarly, there was less than 1% rate of ocular disorders in these children. So generally, at quite low risk if they have no other systemic findings, quite low risk that we will find an ocular or visual problem by screening. By comparison, symptomatic patients had a quite significant risk of visual impairment, 10% in the symptomatic patients, and an even greater risk of ocular disorder. So 1 in 10 patients with symptomatic CMV may have a visual impairment. And if you sort of just keep that number in mind, a little bit more detail there. Now, there was a bit of heterogeneity, so between 0 and 22% were the rates quoted, and you can see that the results are somewhat variable. But of interest, patients who had moderate or severe visual impairment, 75% of those were from a brain-based cause of visual impairment rather than the ocular cause resulting in visual disability. There was no significant difference when we adjusted for diagnostic modality, how the records were recorded, how the studies were done, the population, or the length of follow-up. The commonest structural disorders found in symptomatic patients were chorioretinitis, as you might expect, optic nerve hypoplasia, and anterior segment abnormalities, cataract, congenital corneal opacity, with these kind of levels of prevalence. But when they were adjusted for hearing impairment, children with hearing impairment related to CMV were much more likely to have a structural eye problem. If they were preterm, they were much more likely to have a structural eye problem. And in that pre-2017 consensus, the rates were much higher as well. So, I believe I've got 10 minutes. I'm carrying on. So, in the asymptomatic populations, you can see that the results were more heterogeneous, and these results were robust to omission of individual studies. So that's one way of testing the validity of those data. So an outcome of this paper, we said we were looking to try and understand who should be screened. And the data we have suggest that all patients obviously should be checked at birth if they have congenital CMV. But if they're found to have no ophthalmic manifestations and otherwise are asymptomatic, it's possible that they should just go down the routine, usual screening of any normal child in the population. Of course, there are times here that if there are developmental concerns that arise, or if hearing loss develops later, they could be moved over into the symptomatic group and join ophthalmic screening. Those children with neurological manifestations and, of course, with ocular manifestations should then have regular ophthalmic input. So these are, pooled prevalences are estimates of a level of disease from the literature. The results were somewhat heterogeneous, and CMV is tricky because there are different ways of defining what is symptomatic CMV, and those things do vary internationally. And of course, some of the populations are specifically looking at hearing loss populations, so there may be some biases within those papers. When people did report visual disability, they didn't always make it clear whether that was from an ocular reason or from a brain-based reason. But where it was reported, visual impairment did seem to come from cerebral issues from CMV. There has been a previous similar study published in 2012, and actually our pooled prevalences seem higher in the symptomatic group and lower in the asymptomatic group, so probably more clear-cut in terms of how one would screen. And those differences in result probably do relate to those changes in diagnostic criteria, because if we're better at picking up symptoms, doing more brain scans and looking harder against those diagnostic criteria, there are possibly more children in the symptomatic group than would have been pre-2017. It's really important to note as well that 10% of children who are initially asymptomatic may go on to develop hearing loss, so they do need to be in screening programs. So this study had its limitations, and there was a lack of detailed information in the literature, so we can't be really clear about how screening would be ideally done. Of course, we all know with pediatric ophthalmology, you can't look at a child at birth and tell anyone how their vision is. We are slightly limited by age-limited testing. Of course, there was only a small number of papers that really fit our criteria. And importantly, we know there is a burden of congenital CMV in low-income countries, which were really not represented in these data. So take-home messages. 1 in 10 children with CMV will grow up with visual impairment. And more than that, will have structural ocular abnormalities and will require ongoing eye care. Majority of visual disability that was found was from neurological causes. And with asymptomatic CMV, there is a low likelihood of visual disorders in these children. But remember that there's an increased risk if their birth was preterm or that they go on to develop sensory neural hearing loss. Thank you very much, and all the references are there in our paper, which is in submission currently. Thank you. Thank you.
For the very nice brief up on the CMV. I would like to have few comments from Dr. Dolso.
Thank you, Dr. Naomi, for a nice presentation and enlightening the audience regarding a very important disease which may be responsible for causing disability in the children. So, what you think, how you can advise the people that they can be more, say, vigilant, or they should be more sensitized for taking care of these types of problems?
That's a good question. So in a condition that's not universally screened for, we may be relying on parents to pick up signs, people to be aware of things. So some of the suggestions in the more detailed paper include to have greater public health awareness of visual issues, to have robust screening of all children. Of course, we know you can pick things up at neonatally. You know, in the UK, we have a 2-year check of general development, which may pick up visual issues at you know, starting school. Children's vision's assessed as well. But also parents feeling able to you know, come forward and say, I think, you know, something's not quite right here, is really important, particularly in big populations where screening is not in place. That's an important measure. So it's a very good point.
Thank you very much.
Thank you. As far as India is concerned, around 80 to 90% of the female in ANC period, they are seropositive. So that is the situation in India. And around, I would say, 3 lakhs babies are born every year with CMV positive in India. Thank you, Naomi.
Thank you.
Yeah. So coming to our IC, that is reaching the unreached ways and means. Cataract blindness is really preventable, and India is a vast country having different blindness pattern as per the region is concerned. We have so many ways and means, that is NGOs, private setups, government setups, medical college, and of course individuals. They are all involved through Government of India initiative, but still we need to have a lot of effort. And so to discuss this, where are we, what we are doing, and how to achieve these the targets with the planning, we have gathered here and this IC. So for the first talk, I would request Dr. Nalini Kunar to please enlighten us on the blindness and NGO role in India. Thank you.
Thank you, Dr. Indamohan. Good morning, everyone. First of all, I would like to say thank you to APAO and AIOS for providing me this opportunity to speak from this prestigious podium. The topic of presentation is blindness and the role of NGOs. We would like to discuss the impact, the strategies and the challenges faced by NGOs. Blindness and role of control in role of NGOs in India is great. blindness is a major public health issue in India. NGOs play a crucial role in the prevention, treatment and rehabilitation. Collaboration of NGOs with government, private sector and international organization enhances their impact. Vision, the most dominant of our senses, play a critical role on every facet and stage of our lives. We take vision for granted, but without vision we struggle to learn, to walk, to read, and to participate in school and to work. Visual impairment has serious consequences for the individual across the life course. Many of these consequences can be mitigated by timely access to quality eye care. Eye conditions that cause visual impairment and blindness, such as cataract or refractive errors, are the main focus for eye care strategies. Vision loss can affect people of all ages, however, more than 50 years are more prone. National Blindness and Visual Impairment Survey conducted in 2015 and 19 in India show that 4.95 million people are blind and more than 8 million people suffer from severe visual impairment. This pie diagram shows that cataract and refractive errors are the major chunk of causes. A high proportion of blindness and visual impairment are due to avoidable causes. And what is blindness? Visual acuity less than 360 in better eye with best correction is blindness, and visual acuity less than 612 in better eye with best correction is visual impairment. So, blindness is of two types, non-avoidable and avoidable. Some of the causes of non-avoidable blindness are certain genetic conditions like retinitis pigmentosa, advanced AMT, glaucoma, severe brain and eye injuries, tumors, etc. Whereas major causes of avoidable blindness are cataract, glaucoma, refractive errors. Now, NGOs have a great role in eye care. They arrange awareness campaigns. They are responsible for preventive care, surgical interventions they take care of, and visual rehab and advocacy and policy support is their mainstay. Now, there are few challenges which are faced by NGOs. The challenges are in the form of funding constraints. Regular meetings with funding agencies play an important role, although funds are always wanted and welcomed. Reach and accessibility. Outreach programs sometimes face challenges due to weather, distance, geographical constraint, but God helps us, fortune favors the brave. Awareness and superstition. Awareness is created by trained staff through speeches, and superstitions such as rainy season is not in rainy season cataract surgery should not be done. This is a myth which is to be addressed. Then the surgery is the only answer to cataract, we tell the patients, and glasses will improve the quality of life with patients with refractive error. Skilled workforce shortage. It is not an issue in our college, because in our hospital, because of the availability of paramedical college and college of nursing, but certainly for other NGOs it is. So government and NGO collaboration is very important. NPCB aims to reduce avoidable blindness to 0.25% by 2025, and the chief of DBCS, that is Chief Medical Officer, really collaborates well with us. Ayushman Bharat, launched by launched by Government of India, is a blessing to all the needy. Training programs play an important part. Future strategies for NGO. Expanding telemedicine and mobile eye care units and embracing digital transformation is very important. Strengthening corporate CSR partnership is very important. Increasing community participation and adapting to societal needs is also very important. I am working with a charitable church-based institution, Philadelphia, popularly known as Mission Hospital at Ambala. It is also an NGO and performs many school health surveys. Annually, nearly 50 screening camps for various eye diseases are done in far-flung areas with the help of some NGOs. We perform nearly 2,500 cataract surgeries annually. Other surgeries like squint erigum also are done. Awareness camps by optometrists are done by teaching the villagers. Distribution of glasses to treat refractive error is also done. IOP measuring and fundoscopy for early detection of glaucoma is also done. Surgical intervention at base hospital providing free transportation and meals is also a blessing to the society. Visual rehab is also done in post-op cares by giving glasses. Advocacy and policy support is done in the form of monthly meeting with sarpanches, religious heads, etc. to discuss the means of publicity, accessibility of patients, execution of camp at ground level. Now I would like to show you some pictures showing community ophthalmology work done by our hospital. This is Ghazi Khan, single-eyed patient, was operated by our hospital in Anantnag in 2007. He lost one of his eyes in beer mauling, and the another eye was operated by a hospital. Before surgery, life was not good for him, but after surgery, he said he could see his food in the plate, he could go to the washroom, he could clip his nails and mustaches. It was a life turned 360-degree good for him. Second picture shows bilaterally blind couple suffering from hypermature cataract. They were very anxious before they came, but they were holding hands in hands, still they are. And so on day 1, either eye was done, and on the day 2, the next eye was done. And when it was done, they were very happy. So this is an old picture when SICS was done. Now we are doing phacosurgery in all cases. These are few pictures which show all the activities done in camp, that is taking vision, doing fundoscopy, then optometrist doing OPD, lab technician ruling out diabetes by doing blood sugar. I would also like to address few key NGOs working in blindness prevention: Sankara Eye Foundation, Arvind Eye Care, Mission for Vision, LV Prasad Eye Institute. These institutes are doing really good. So in conclusion, I would like to say that NGOs have significantly reduced blindness rates in India, but more investment, awareness and collaboration are needed. With sustained efforts, preventable blindness can be eradicated. All we need is teamwork. Together, everyone achieves more. Last but not the least, true perfection is a bold quest to seek. Only the willing and true to heart will seek the betterment of many. Socrates. Thank you for a patient listening. Thank you.
Thank you, Dr. Nalini, for enlightening us about the role of NGO in India. In the meantime, I invite Dr. Kanshak Marwa for his topic on bridging gaps in vision care through public-private partnership NCR. And I request Dr. Harjot Madan and Dr. Manpreet to please join us on the dais. Dr. Harjot and Dr. Manpreet to join us on the dais. Dr. Kanshak.
Very good morning to an august audience, and thank you to Dr. Indramohan and the panelists. So thank you to Dr. Nalini ma'am for making my talk a little easier and sharing the difficulties which NGOs have for doing eye care. So bridging gaps in vision care through public-private partnership in NCR region. So I am practicing in Delhi and Gurgaon and Noida and Faridabad regions. So these are basically the near capital regions, and it is mostly the urban population that we are catering to. And so there is a lot of there are a lot of hospitals, but still people miss out on the healthcare. So about the global blindness statistics, that IFBB at Vision Atlas and the Lancet Global, the 90% of the vision loss can be prevented or treated. So most of the vision loss and the blindness that we have and the refractive errors that we have, so the number is humongous. So we have to, as private practitioners also think each one can do something. So each ophthalmologist has that, that potential to take care of so many people. So at least 90% of the vision loss which can be prevented or treated. So I think with technology and other things which are, upgrading in ophthalmology, and you have now non-mydriatic cameras and fundus photo cameras through which our screening of glaucoma patients and diabetic patients have become much more easier. So like 10% of the vision loss from the conditions that require ongoing management, treatment, vision rehabilitation can be, very easily tackled. So these are basically the statistics in India, that 4.95 million, there are blind people which are there, and 70 million people who are impaired. And there are many causes for it, and the maximum cause is the cataract. So there is still a lot of cataract burden which is there in India, and related to cataract, diabetic retinopathy, glaucoma, these are the other things which actually lead to the visual impairment. So these are the various areas. The more orangish or the reddish parts are where the load is the maximum. So where is the role of the private practitioners? So once I started my residency, I was, part of the screening camps in and around Ahmedabad. So this was my first camp. When I joined my residency, it was the first month itself, and one of my colleagues, senior colleague practitioners, asked me to, do a screening camp for the. So this is my first venture into doing the camp. So I just kept this photograph since like now it's almost 19-20 years, and I still have it with me. So once I started my private practice, then in and around my clinical area, there were many RWS societies. So RW is a resident welfare society. So usually in most of the cities, metro cities in India, you have RWS cities, and there are where you can go and make people aware of diabetes, glaucoma, so that most of the people don't even know about such conditions. Despite so much of modernism and scientific advancement, still people are unaware. So we started evaluating in the neighborhoods, and we found that still there are many people in and around us with like somebody is a guard and their kids come around and show to us, and then we make sure that these kids don't go back, because if you're not treating that refractive error, and we make sure that we give them glasses or something we do from our end as a private practitioner. So and we also align with the general practitioners, and because they screen for diabetes and other things, like ma'am was saying, like NGOs have a big helping task force, but our helping task force are usually the GPs. So they help us, to align the camps with the diabetic screening camp. So if they are keeping a diabetic screening camp, then we also do a general eye checkup camp. So here you can see we have actually done a diabetic screening camp, and we screened around 100 people for diabetic retinopathy during this camp. And we partnered with the neighboring schools also. So the private schools also we partnered, and we do screening, because sometimes private schools also have a charitable wing where in the evening they have children who are coming from the neighboring societies, and they get education. So we screen for them also. And definitely, keeping glaucoma awareness and things awareness about diabetic retinopathy, which is much needed. So we keep organizing small activities around our neighborhood, and usually March is a glaucoma awareness month. So that is the time when we raise awareness all around the world actually for glaucoma. And during celebrations and community services like Saraswati Puja and other festivals, so around that time when other things are going on, then we associate and sometime with the local shopkeeper associations that in and around our areas we also do. So Nehru Place is a very big area where there are shops. So we, because most of the shopkeepers spend time with the businesses. So they are like from morning 9 to evening 9 o'clock, they are spending 12 hours during this. So they don't get the time for their health checkups. So we organize that also. And we organize with various corporate hospitals also. So as an individual doctor, I am associated with many private corporate hospitals. So sometimes we cooperate with them and with the other NGOs like Satya Sai, and there are many in India. That is the boon that there are so many charitable organizations which are there. So you have to you can cooperate with so many other local sanस्थाs or corporations, you can say. So we collaborated with Delhi Police also, and we did a lot of camps with them. And we collaborated with various religious organizations like Radha Swami Agra medical camps. So we did screening for them, and we do it regularly. So and we organize with the charity missions also, like the Christian charities here. The doctor is she has her own practice, and she invited us to screen for people. So we screen 100 people there. So good team is definitely very important. So main our strength are the optometrists, and they help us screen people, and they form a very good team, which is essential to screening. So we also did a screening camp where we screened 6,000 kids in 2 schools, 2 government schools, and so you can see in the lower photograph there's so many girls who are myopic. So in one of the classes there were 50% of the girls who were myopic. Where this is a 6th standard class, but like junior high school, and so I've just taken a photo of the autograph also, that it is -5 and -2 cylinders, and so many kids wearing glasses. So it has actually increased over the 10 year of practice, 15 year of practice, which we are seeing. The myopia has definitely increased, and we distributed the glasses also to these kids in the schools. So we do our private eye screening at our clinics in Gurgaon also, and this was done in Tughlakabad area, and this was done in 18th February 2024. We do regularly at Najafgarh. So every month we organize a camp. So it is throughout this thing. I'll not take much of time. And so these are just a few photographs from that. And what we do is also we sometimes take spectacles, old worn out spectacles from people, because once you use it, maybe you throw it at 6 months, but it can be used again with proper putting of the lenses, and it can be used again. So we have done that kind of donation. These are the regular camps we have done in and around Delhi. And this is the spectacle distribution where we refurbish the plastic frames and put in the new lenses and give to kids. So this was a class 12 student who actually donated a lot of 100, 200 glasses for this cause. So this we did in many schools in and around Gurgaon also. 4 schools we did covered, and we did with Earth Savior Foundation also. On 19th of October, we screened 100 people. So we are constantly trying, and whatever small things we can do, but with obviously with the cooperation of the NGOs and the government, we can do a lot of things together as a private practitioner. Thank you for this talk.
Yeah, thank you, Dr. Kanshuk. So in the meantime, I invite Dr. Manpreet Kaur to have his topic on collaborative models for addressing blindness, different approaches. One point thing on Dr. Kanshuk's by Dr. Dole or Dr. Rohan. One point.
Thank you, Dr. Marwa. It's really a good job. And I expect all this from my other colleagues also who are involved in practice. And I always tell that this is a specialty, this is an area which gives an opportunity to serve the humanity. And if you spare minimum half a day in a week for this job, it pays you a lot. And I may tell you it's not free. You are doing free, but dividends are very high. Means those people who get benefited, they are your ambassadors. They tell other people that look here, there is a doctor who examines you free. And one area which must be covered is, which we are forgetting, is the urban slums. There are a lot of problems. We focus on rural areas. We talk about rural area, but urban slums are equally bad. Thank you very much.
Thank you, sir.
One comment from Dr. Harjot Madan.
Dr. Kenshuk, you are doing very good work. Just one point I would like to add. Like you said, in schools there were more than 50% of myopic kids. And I think there should be awareness about the use of digital devices also, because kids are using mobiles a lot. So this is the main reason of increasing the myopia. So they should be given awareness.
I think this problem is more COVID induced, because before COVID we could
Yeah.
tell the parents that don't use
Yeah.
digital devices.
Yes.
But after COVID,
After
there's
COVID,
so many online
हाँ.
classes and this thing that
So they get excused.
Yeah,
हाँ.
so they say that Papa फिर किस पे पढ़ाई करेंगे,
Correct.
and kids are so smart that while they're attending the classes, they would put up an online game and do the gaming with that.
And myopia management is now a regular part of any eye care organization, whether it is private or charitable, anything. So we need to focus more on particularly urban areas where the consumptions of this digital gadgets are more. So it's like very nice presentation. Thank you.
Thank you. Especially the school children, they need attention at that age. So, thank you. So, over to Dr. Manpreet Kaur.
Good morning, everyone. So I would like to thank APO, IOS and Dr. Indaman Rastogi, sir, for providing me the opportunity. So my talk is about collaborative models for addressing blindness, different approaches. So I will begin with the famous quote of Helen Keller: of all the senses, sight must be the most delightful. So we know that vision is the most dominant of our senses and plays a critical role in every facet of and stage of our life. So according to WHO, at least 2.2 billion people globally have a visual impairment, and out of these 1 million cases, this impairment could have been prevented or has yet to be addressed. And coming to the Indian scenario, so to assess the present status of blindness and visual impairment in India, the Ministry of Health and Family Welfare, it conducted the National Blindness and Visual Impairment Survey in the year 2015 to 19, using the rapid assessment of blindness, avoidable blindness strategy in individuals above 50 years across 31 districts of India. And the results estimated the national-wide prevalence of blindness at 1.99%, and out of that, cataracts were the main cause, accounting for 66.2%. So these are the definitions which are used, that has been covered by Dr. Nalini ma'am, and we can see that 85% of the blindness is avoidable or preventable. So coming to the definitions, the two have been covered. So what should be the approach? How we can approach this burden? So there are two ways. Either we should continue to do what is being done and has been giving good results, and second is we should strengthen the ongoing activities and adopt innovative strategies. So there are certain challenges also. The first and the foremost and the biggest, according to me, is the inequality in the workforce distribution. India has around 15 ophthalmologists per million population and 39.1 optometrists per million population, but there is a significant disparity between urban and rural areas. Urban areas have a ratio of ophthalmologists of 1 per 10,000, whereas in rural areas we have only 1 per 2.5 lakh population. So there are certain obstacles also in reducing this preventable blindness at the consumer end. What are they? So there is less utilization of the eye care services due to less awareness, low literacy levels, low socioeconomic status, older age, geographical barriers like hilly areas, desert areas and tribal areas, lack of transportation facilities, lack of social support such as finding an escort to or obtaining permission from the family members, especially husbands for women patients. So these are the major obstacles, and how we can approach these. So the rational approach would be divided into 5 parts. First is by raising the awareness. So a comprehensive public awareness campaign is required to educate people about the preventable causes of blindness, about the necessity of regular eye examinations, and the availability of the free or low cost eye care services, and this can be done through multimedia marketing, community engagement programs and collaboration with local organizations. In addition, regular IEC activities, they should be taken yearly all around on World Glaucoma Week, Eye Donation Fortnight and World Sight Day throughout the country. So these events, they highlight the need to healthy lifestyle for prevention of avoidable blindness. Second is to increase the access to the eye care services. So India must invest more in eye care facilities in neglected and unreached areas to overcome the urban-rural divide. So this can be done through mobile eye clinics and teleophthalmology. The government should collaborate with NGOs and commercial institutes to guarantee that quality eye care is provided to all. And there should be continuous emphasis on primary eye care by establishing vision centers in all PSCs. There should be development of mobile ophthalmic units in district levels for patient screening and transportation. And to make eye care more comprehensive, besides cataract surgery, there should be provision of assistance to other eye diseases like glaucoma, childhood blindness, corneal transplantation, etc. And more involvement of the private practitioners and NGOs in the program. A word about teleophthalmology, we know it is the latest tool in utilization of the diagnostic and therapeutic management of eye care. So India has been a pioneer in this development as well as application of this practice. So there are certain successful models like teleophthalmology for control of diabetic retinopathy. Arvind Eye Care and Shankara Nethralaya, they were the pioneers, and they were held to a larger extent by ISRO and World Diabetic Foundation. And one more example is teleophthalmology in the management of ROP. So Narayana Nethralaya in Karnataka started this KID ROP program for the diagnosis and management, and it was such a success that the government of Karnataka adopted it under its rural health scheme. And more about public-private collaboration, this has been discussed beautifully in previous lectures. So I will quote some successful global models like Vision 2020. And coming to India, there are 2 states, Madhya Pradesh and Maharashtra, where the collaboration of NGOs and government, it took beautifully, and they conducted many surgeries and helped in reducing the cataract backlog. And the best to me is the declaration of India free from trachoma by the World Health Organization on 8th October 24. So this was a big feast of victory for us, and this is the best example of public-private partnership. Third is to subsidize and provide subsidized and free eye surgery. India is already doing this. So in India, free eye surgeries are available through government schemes like Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, National Program from Control of Blindness under Netra Jyoti Abhiyan, ECHS, CGHS and state-sponsored health initiatives, and through charitable organizations and hospitals. There is need to involve more corporate sectors to execute corporate social responsibility for cataract surgery. These are some government and some state level schemes which are providing free surgeries. A word about mission mode cataract surgery campaign or Netra Jyoti Abhiyan. So this was launched by the government in May 2022 so as to reduce the backlog or to clear the backlog of eligible cataract cases by allotting yearly targets to each state and union territory for the year 2025. I think this should be taken in the next lecture. So another method is to replace the traditional camp approach by this hub and spoke model. So the traditional approach, we know it was very tricky. It has variables that are not justifiable, you can say, that are not standardized. So if anything happens, some vision threatening complication happens in camps, so that may lead to a very serious medico legal implication to the surgical team. So this model, it should be replaced by this hub and spokes model, where the patients are mobilized and screened from the spoke side and they are transported to the hub site, that is the central hospital, where the cataract surgeries are taken by a trained and skilled workforce. So this model has various advantages, right from vertically integrated to cost effective and equitable. So this is has been successful in several parts of the country, and the replication of similar models should be done in the needy populations. Fourth is professional development for healthcare workers. So continuous education of the healthcare professionals, especially in the rural areas, and training and implementation of the high volume low cost cataract surgeries like manual small incision cataract surgery. And fifth is the research and data collection on the prevalence of preventable blindness. So continuous data collection and study on the prevalence and causes of blindness in India are critical for developing successful strategies. This data can be used to guide policy decisions and targeted initiatives. So the take home message, so a multifaceted approach is required to solve the issue, including awareness to research, and with the combined efforts of government, NGOs, healthcare professionals and general public, we can turn the tide against the rising blindness in India. So these are the references, and I will again end with Helen Keller. Alone we can do so little, together we can do so much. Thank you.
Thank you, Dr. Manpreet Kaur. Definitely, if we are, work in unison, we can achieve more. So that is truly said. And now I invite Dr. Chan Singh Dhul, who has seen, his, I would say, the days, the things were different in community ophthalmology. Now the things are different. From, I would say, institution-based things, the community ophthalmology has shifted to individual base. So let's hear Dr. Dhul sir, community ophthalmology now and then. Dr. Dhul sir, please.
Good morning, everybody. First of all, I must thank APAIO and especially Dr. Inder to be with you. My job has been simplified by the previous speakers, especially Dr. Nalini, Dr. Marwa and Dr. Manpreet Kaur. Say where we were and where we are now. That's my area of discussion. I've been fortunate to be associated with this specialty, with this program, since its inception in India. When I was a resident, then SR, and when this program was started in 1978, and I joined as SR in 79. So my HOD used to take me to those areas, and I said, sir, what I will do? He said, you will see what is happening there. And the program started in NPCB, and in Nirban Bhavan, lot of meetings, lot of discussions, and people used to tell their stories, the advisor from various states. And what was the state of affair before that we are going to discuss. I don't know who have seen those eras, maybe Dr. Inder or Dr. Nalini or few friends who have seen those traditional camp approach and what community ophthalmology definition used to be, that people were being operated by the quacks at that time. Those were the days. So we have passed through that journey and we achieved a lot, but still we need to do more, because we have been playing with the jugglery of figures. I think Rohan will agree with me. We have been saying that since long that we are going to achieve our target, that 1.4 to 0.3%, but we don't know where we stand till date. After so many years, so many programs came, Vision 2020, and say achieve the vision by 2020, but that also has passed for the last 5 years. So let's say what used to be. We have seen that era of these surveys. The priority used to be National Trachoma program, where we have seen people with inverted lids and complications and blindness and whatnot. Those were the days. And then vitamin A deficiency surveys. Again, that used to be a big problem. Before 80s, I am talking. And the community of Thilon was limited only to the few places. That means we used to treat them at a fixed base hospital, or if at all some NGO came in, we used to organize the camps in the rural areas, in a school or in a dharamshala or anywhere, by compromising so many things. So then Patricia Bart defined this. She came with an idea that why not to take care of these people, this blindness program, with the use of public health knowledge as well as with the use of community knowledge. That means, of course, in case of trachoma, environment, sanitation, pure water was playing a big role. And that's why she felt the need that why not to utilize this specialty or this knowledge to use for taking care of the blindness. And at the same time, the community ophthalmology knowledge for educating the people, for say doing surveys, for detecting the problem, and unless and until we know the magnitude of problem, we can't solve it. So for knowing the magnitude, we do have that knowledge. Before it is, and of course now it is also, some of the NGOs were in the field, like Lions, Rotary, Sight Saver, established by Sir John Wilson in 1950s. He was the gentleman who donated all his property and started this NGO. And later on, he formed IAPB, and he was the first president of International Agency of Prevention of Blindness. So he was bent upon convincing the people. I met that man, I had the opportunity to meet, I was talking with Naomi, that he came to, for delivering a lecture and for, say, giving us the diplomas when I passed my DCH from Moorfield, London. So I had the opportunity to meet that man. And I saw that man who was not even a medico, for attending all the conferences, ophthalmology conferences, international conferences, and delivering the lecture and convincing the people, convincing the ophthalmologists that what you can do in this area. So that was the zeal of the person. So role of NGO is very important, I may tell you, as say Nalini has pointed out or other colleagues have pointed out. Then National Program for Control of Blindness came in 1978, and we were fortunate that the government at that time, say, adopted it under Prime Minister's 20-point program in 1982. So the stress was laid under this program to educate the people. I may say education is very important. And how I got motivated, I will tell you that when I joined as an SR and I later on as an AP, and I asked to do a medical board for a person who came there. My HOD marked it. And I was in pains in declaring a person unfit who was selected as a DSP in Haryana, having amblyopia in one eye. Look at the situation. The person is having 6.6 in one and 6.24 in other. And I had to say him that, gentleman, you are not fit for this job. And there was no remedy for that. So look at the pity of that man. Had somebody educated him during his school days that or screened those children and did help them, he would not have faced that problem. And another example was a gentleman having color blindness was to be declared unfit by me, that he was not fit for the job of his security service. So look at these situations, why these situations arise. If we are vigilant, or if we play our role screening the children in the schools and telling them that look here, these are the jobs for which you are not fit. And even nowadays they have done some relaxation. People with color blinds were not declared fit even for MBBS admission. But later on his condition was relaxed, and now they said that yes, you can do the study, but you can't be declared fit for a government service. So these were the situations, and that's how we can help these people if we are vigilant enough. So the stress was laid on infrastructure development, health education. That means whatsoever are the facilities existing, we must strengthen these at the primary level, at the secondary level, as well as at the tertiary level. That was the aim of this NPCV. Of course, the stress was laid by declaration of the Alma Ata on primary health care, because very important, because everything starts from there. As say my colleagues have told, that there is a disparity. Lot of ophthalmologists are there in our country, but there is an urban-rural bias. So we can't press or we can't force the ophthalmologists to be in the villages, but at least we can serve in the villages while sitting in the cities. Now again this program was renamed. Why? Because it's not blindness which is important, visual impairment is equally important. Because if somebody is not fitting into the definition of blindness, that vision less than 3/60, still there is a problem with the people who are visually impaired. So under this program, the more stress was laid, whether it was Vision 2020 or it was NPCV and VI, the stress was laid that we should approach in a pyramid fashion. That means we should lay stress on primary eye care, secondary eye care, and tertiary eye care. And apart from that, the center of excellence or the apex institutions. In those days, RP center used to be the apex institution, but now there are 5-6 more institutions. We are playing a great role to be an apex institution. What is this DBCS? So under this national program, it was planned that we should lay more stress on the district level, in the secondary level. And there how we can approach, because people who have been working in the government setup, they know the hurdles, they know the bottlenecks. Where lies the problem? If somebody wants to purchase equipment for his hospital, there was a long channel. So DBS was, it was simplified that we should make a society and we can go through or we can solve these problems, these society approaches. Then it was included along with other programs, and it was renamed as District Health Society. Instead of only focusing on the blindness, certain other diseases were included. At the district level, the civil surgeon was empowered to make a society that is a District Health Society. Now what we have been doing, that has been discussed, I am not going to repeat it, that outreach, screening camps, health education, training of health worker was equally important. And in this I may tell you, because as we are talking about that there is a dearth of say ophthalmologists, but at the same time there is a scarcity of these people at places where we can't reach. So how to reach them? So an idea came and said we can train even the school teachers. And when I looked at the literature, there were so many publications. In 95, one of my colleagues, Hans Limberg, who happened to be my classmate in Moorfields, so he did the job in India and screened almost 4.5 million children with the help of school teachers by training them. So still you can train them in the schools and they can do the, I will take few minutes on. So with the help of school teachers, we can get the vision screening done, and they can refer it. And a lot of studies have been conducted. If you search the literature, they play equally good role as the optometrist, or hardly there is a difference of 5-6% data. Then came the era of IOLs. So it was not limited to those ICC and the fake glasses. IOLs were introduced, and we can provide the same quality of services to the rural folks with the help of this new technology. So what is now? Dr. Manpreet has talked about it, and so many other colleagues also, that it's not limited to cataract approach only, because there are other diseases which are equally important: diabetic retinopathy, posterior segment diseases, glaucoma, which may cause a permanent blindness if you do not take care. So in those cases, the teleophthalmology plays a role, and naturally with these gadgets, by training the people at the primary health centers, at the vision centers, we can place the gadgets there and reach to these peoples. So we can bridge that gap of urban and rural with this. We can play a role in preventing the blindness for getting into, and it is cost effective and efficient, because you require less manpower, and sitting at the cities, you can examine and you can give opinion to these people, and you can do the screening, you can do follow-up, you can do emergency consultation. Suppose there is a patient of acute congestive glaucoma and the guy sitting at the PHC doesn't know what to do with that. So with your opinion, you can guide them that, look here, you can manage this patient like this. So there are few advantages of teleophthalmology, as we have discussed, but there are disadvantages also. And what are those? That there is a limited diagnostic accuracy. We can't give, facility or that opinion which we can give by examining a patient, but only just by looking at the data. There are limitations. Then technical and connective issue in the villages, net is down. Somewhere the facilities are not existing, and the people are not able to connect to you. So that is the problem. Lack of skilled personnel. The person who have been assigned the job, he doesn't know how to update the data, how to load the data. So these are the problems. Then of course legal and ethical, because in these cases we are likely to miss something, and there is a limited scope of treatment while sitting at a distance, and of course it requires cost. Thank you very much.
Thank you, sir. So now we request, thank you for enlightening us, the community ophthalmology from the days back in 1950s, 60s, and these days things have come a lot forward, from individual toes to things have come to the teleophthalmology. Thank you, sir. So now I invite Dr. Hiteshi Shani for his talk on initiative under NPCB for cataract blindness intervention in Haryana state. Dr. Hiteshi.
First of all, I would like to thank AIOS, APAO, and Dr. Indamohan Rastogi for giving me the opportunity to present on this prestigious platform. So the topic given to me is initiatives under NPCB for cataract blindness interventions in Haryana. So first of all, a brief overview of the state of Haryana, which is composed of 22 districts, and the population is about 30.2 million. The prevalence of blindness in the population is the same as the national, 0.36%, and the prevalence of blindness in more than 50 years of age is 2.21%, whereas the national one is 1.99%. Under the leadership of Director General Health Services Haryana, Dr. Kuldeep Singh, and the State Program Nodal Officer, Dr. Jagdeep Singh Basur, the NPCB works for the betterment of the people. Now, what is the present scene? The burden of the disease. In Haryana, approximately 1.35 to 1.5% of individuals aged 50 plus are blind due to cataracts. This translates to roughly 13 to 15 blind individuals per 1,000 in this age group. This is according to the survey conducted by NPCB from 2015 to 2018. Nationally, the longitudinal aging study in India indicated a cataract prevalence of 12.2
0.25% among adults aged 45 plus, with Haryana showing a lower state specific rate of 9% for females and 8.7% for males. Now, the burden of the disease vis-a-vis Haryana and our country, India. Cataract blindness in more than 50 years of age in India is 66.2%, whereas in the state of Haryana, it is 60.5%. Severe visual impairment due to cataract in more than 50 years of age is 80.7% in India and 53.7% in Haryana. Cataract surgical coverage for blind in India is 93.2%. In Haryana, it is 96%. Now, microplanning for declaring districts cataract blindness backlog free Haryana. We say a goal without a plan is just a wish. So the team works at planning and executing. Various campaigns that have been proposed in our country are Cataract Blindness Backlog Free, Rashtra Netra Jyoti Abhiyan, Pradhan Mantri Motia Bind Mukt Bharat Abhiyan. Now the assessment that we have already done, we have assessed the disease burden. Then we have to assess the available screening capacities which are available, and then of course the surgical capacities. Now the human resource management, it works in a 3-tier system. First of all, a primary screening is done by the ASHA workers, the Anganwadi workers, the multipurpose health workers, and volunteers. The confirmation is always done by the optometrist and the ophthalmologist, and then come a team of surgeons, OT assistants, and nurses. Now, how do we evaluate the program? Minimum benchmark standards for declaring a district cataract blindness backlog free, they have been laid down. The cataract surgical coverage for blind persons, that means whose visual acuity is less than 3/60, should be above 98% to declare the district cataract backlog free. The post-operative complications leading to blindness in the operated eyes should be less than 2%. The visual outcomes of cataract surgery should not be less than BCVA of 6/60 in more than 5% of operated cases. This is as per the WHO criteria. Now, the cataract surgeries in our state for the past 6 years. Now, you can see the data, quite a number of surgeries have been done. Now, in the year 24-25, we have the data up to the month of February. 30,248 cataract surgeries were done in government sector. The NGOs helped by conducting surgeries about 13,226. Of course, the private sector, the number is bigger. 1,43,989 surgeries were done, which comes to a total of 1,87,463 surgeries. Now, the NGOs play a very important role, and under NPCB and our government, state government, they clear the funds of these NGOs as soon as possible, and they have been encouraged. So, in the year 24-25, 13,226 surgeries were done in the state of Haryana. Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, we know this is a pet scheme that had been launched by our Prime Minister. It was launched in the year 2018. Cataract is one of the approved packages for private hospitals in our state of Haryana. Eye hospitals empaneled under Ayushman in Haryana are 245. There is a Charayu scheme that works in Haryana. In this, all Antodya families of Haryana are included, and it covers a population of about 1.59 crores. Cataract and other eye surgeries conducted under Ayushman Bharat Abhiyan. So we can see in the year 24-25 only 1,03,283 surgeries were conducted under the Ayushman scheme, and other eye surgeries under Ayushman scheme were 22,726, which is quite a number. Now, what are the initiatives in government institutions? NPCB has been proactive in strengthening the medical colleges. We have provided equipment worth rupees 1 crore to Medical College Rohtak, Sonipat, and New. Facilities of phacoemulsification with foldable IOLs have been provided in every district hospital of Haryana. All the conditions to declare a district CBBF, that means cataract blindness backlog free, have been fulfilled for district Gurugram and Ambala. Equipment worth rupees 10 crores have been installed in the districts recently. Now, Center of Excellence at Panchkula, this is the place where I am also working. So we have, with the cooperation of Hero Motor Corps under CSR, equipment was donated, which was worth rupees 2.6 crores, and the latest Centurion phaco machine, Zeiss Angioplex OCT, Humphrey perimeter, and green lasers have been installed at our center. Now, DNB courses. The department is very proactive in enriching the department and providing training to the budding doctors. DNB ophthalmology courses are available in District Hospital Panchkula, District Hospital Ambala City, SDH Ambala Kent, District Hospital Faridabad, District Hospital Palwal, and SDH Bahadurgarh. Now, what is the way forward? Now, as everybody was emphasizing on telemedicine, we also want to use digital technology, AI tools in screening blindness, and diagnosing cataract through teleophthalmology. Also, we want to give cash incentives to ASHA workers and volunteers for bringing cataract blind patients for surgeries to government hospitals and NGO hospitals, because we all know that the periphery still remains missed out. We are still getting hypermature cataracts, so we are very proactive in getting those cases well on time. Last, thank you for listening to me.
Thank you, Dr. Hiteshi. So, I request Dr. Ruchi to please come over on the dais. So, the government of Haryana, of course, doing a lot, and you know, the nice initiative under all these government-sponsored schemes. So, thank you for enlightening that. Dr. Ruchi Dabas will speak for Dr. Manisha Rathi. Please.
One comment, please.
Yeah.
Actually, in government setting, the cadre of community health officer is there, and so much emphasis is going on collaboration and cross linkages. So we have well-defined criteria how these cross linkages are utilized by NGOs even. So kind of as Dr. Manpreet Madam emphasized on collaboration, we can take help of government machinery for our advantage, because NGOs are also working with the same purpose. So we have a detailed guideline on NPCB VI website, where the role of CHO and the people working under them very well defined. Second thing is cross linkages. Cross linkages means as far as government health sector is concerned, we can it is like formulated for that, but we can also take advantage of it, because the PHC people, the patients coming to the PHC are referred to the higher centers, not to overload them, but at the same time the people or patients has not to have that resource spent so much on their small ailments or eye related problems. So the now more emphasis is on cross linkages as well as collaboration with the government, as Madam rightly said, PPP model.
Yeah.
Thank you.
Thank you.
Your
Thank you,
your
Dr.
And also the NPCB is clearing in Haryana. There's no problem of clearing incentives or funds. Means they are cleared on time. Only during COVID we had a dip for the NGO cooperation. Now again it's like full on working.
But Haryana is doing very good.
Yeah.
In a sense, DNB program is also
Yeah,
there in
Yeah,
at
in
district
every
hospitals.
hospital.
That is
Yeah.
not even in Gujarat.
Yeah.
So it is
And we are
wonderful to
training
note.
doctors, they are passing at very good rates.
Dr. Hiteshi, I slightly differ. Means, or rather, I would like to know from you that what efforts are being made by the government in streamlining the process of payment either to the NGOs or to the private hospitals for these cataract surgeries.
Sir, in private hospital like Ayushman Bharat, in NPCB and the state of Haryana, they have covered Ayushman Bharat for private hospitals also. The private hospitals are giving free cataract surgery.
Agreed. My focus is on pending payments.
So they have been cleared on.
No, I may tell you,
In
the
Punjab,
hospital
the
where I
scenario is
am,
different.
it's worth 1.3 crore, which is
Yeah.
pending for
In
the
Punjab,
last
the scenario
10
is
months.
different.
That-
Yes.
that's
That
right.
is the last 10
Haryana.
months.
Okay, I'll take
And same is true with NGOs for whom we pay only for cataract in the government sector.
Sir, for
Yeah.
I'll take up your case with the NPCB, but sir, for most of the cases they are being cleared on.
No, no.
Because I have conveyed this to your HIAPS also, because Dr. Kuldeep, he has been working with me as DMS when I was a medical superintendent and director, and so I told those people also.
Thank
But everybody is helpless, I may
payment,
tell you.
definitely payment is the issue.
Means
and
I may
that is
tell
the-
you the health functionaries are helpless in making the payment.
Yeah.
Even if they intend to,
Yes.
still it is in the hands of the bureaucracy and the finance department.
At the same time, health is a state subject, so state is independent to do. That's why this discrepancy. Because
Payment issue
Maharashtra,
is
Andhra Pradesh
definitely
doing
out
good.
of context of this session. So thank you, Dr. Hitesh. Definitely it needs a raised concern also. Dr. Ruchi.
Good morning, everyone. Respected chairperson, moderators, and thank you, APO, for giving this opportunity. I'll be talking on low-cost, affordable eye care and blindness control through community outreach, Haryana. The magnitude, that is more than 2.2 billion people, they have visual impairment globally, and out of which 1 million is preventable. But the sad state of affairs is that 36% of these people with impairment due to refractive errors and 17% with cataract, they have received access to the appropriate intervention. And as a result, this impairment poses a global burden of US dollars 411 billions. And this affects usually more than the age of the people, age of 50 years. And again, the sad state of affairs is in our low and middle income regions, which is about 4 times higher than in the high income regions. The goals and objectives of NPCB, which is being followed by Haryana for community outreach program, and for which I would say I'm grateful to Chand Singh sir, Dhul sir, that when I was a postgraduate student at RIO PGMS, was the head. And we had great opportunity to learn and implement these community outreach programs under the leadership of Chand Singh Dhul sir. So their main objective is to reduce the backlog of blindness, to develop and strengthen the strategies of NPCB, that is the eye health intervention of visual impairment, to enhance the community awareness, to increase and expand the search for the prevention of these blindness causes, and to secure more participation of the voluntary organizations and the private practitioners. The major causes of blindness in Haryana are cataract, refractive errors, glaucoma, corneal opacity, trauma, and vitamin A deficiency. Also, all the districts in Haryana, they have been sensitized for the newer components like diabetic retinopathy, childhood blindness, glaucoma, vitreoretinal surgeries. Again, why do we need these outreach programs? As we know that as more early is the age, that leads to the delayed motor, language, emotional, social, and cognitive development, which has lifelong consequences, which later on affects the quality of life also. So, we need early detection and timely treatment. As we know that the diabetic retinopathy, glaucoma, they are most crucial to avoid the irreversible vision loss. And it's so easy, like the spectacle correction for the refractive error and the surgery for the cataract surgery, but the sad state is that only 36%, as already discussed, with these refractive errors, and 17% of with cataract, they have access to the quality. So WHO response for this is that the guidance by the recommendations of the WHO World Report of Vision 2019 and resolution on the integrated people-centered eye care, which includes preventable blindness and the visual impairment, it has been adopted at the World Health Assembly in 2020. Its key proposal is to make the integrated people-centric eye care and to ensure its widespread implementation. Some of the WHO's key areas of work and activities in the prevention of blindness are, that is working with the member states and other partners in the field to monitor the global targets for 2030 on IPC, to develop reports of coverage of eye care indicators to monitor the progress, and to develop resources and technical tools to support the integration of eye care into the health information system. Measures which have are of use are the World Sight Day, which is an annual advocacy event. We are supporting the integration of eye care in healthcare systems through the implementation of a series of technical tools like the eye care in the health system, that is a guide for the actions, the package of eye care interventions, the eye care competency framework. Now the development and implementation tools to support the countries to assess the provision of eye care, The, these tools, they have been very helpful. That is the eye care situation analysis tool, the tool for the assessment of diabetic retinopathy and management, tool for the assessment of glaucoma services, tools for the assessment of refractive services, and the tool for the assessment of rehabilitation services. Various materials and resources have been developed to raise awareness, that is like the Myopia Aid, which is a mobile health toolkit for myopia to increase the health literacy, a population facing app for near and distance visual acuity testing, graphics which promote the healthy eye habits. Like in our institution every year, like during the World Glaucoma Week or during the World Diabetes Awareness Week, we organize the rural and the outreach programs, which are cornerstones in the prevention and screening and prevention of the blindness. This camp was organized last year where 825 patients were screened, and this year again it was organized during the Glaucoma Awareness Week. So this way we are doing the outreach programs in Haryana to increase the awareness and prevention of blindness in the various districts of Haryana. Thank you.
Thank you. This is basically a true model of spoke and hub. So the government, as Dr. Hiteshi has told, that what the government is doing, and now the second wheel, that is the government medical college is doing. So thank you, Dr. Ruchi. So now I invite Dr. Rohan Cheriwala, who will tell us something about the RAB survey in government in the state of Gujarat and Maharashtra. Dr. Rohan, please.
Yeah. Thank you, sir. Thank you, APAO, AIOS, and Dr. Rustagi, sir, for giving me this opportunity to present our survey. So I'll be talking about rapid assessment of avoidable blindness, their results in the tribal regions of Gujarat and Maharashtra. As you know, actually many of might not be knowing that RAB is a very cheap method. It's like resource limited way it happens, and it doesn't involve the less than 50 years of age population. So the time taken for survey is lesser. As I am not going in details in the magnitude of blindness, because many of the speakers have already covered it. So I am directly going towards my study area population. We studied in 6 taluks of Gujarat and 1 taluk of Maharashtra state. Rationale was ours was a new NGO, and we needed the magnitude of blindness as well as visual impairment and all. At the same time, we wanted to know what is the what are the causes of blindness in that region, to make good plan for future. So our aim was to evaluate the magnitude and cause of blindness and visual impairment. Objectives were the prevalence of blindness and visual impairment among people aged 50 plus in this area, the causes of blindness and visual impairment. This has been covered, so I am skipping it. As far as material and methodology is concerned, this is a RAB standard protocol questionnaire which is validated, and this is it. We have to fill in data in this form, and we get we should do entry and get the results. So sample size was 4850 in these 7 taluks. Total of 97 clusters were covered, each comprising 50 individuals, 50 plus age group. Prevalence was defined. Prevalence of blindness was defined as 316 better eye with best correction. Survey teams were formed and they were trained. Training was done by the standard trainer for Southeast Asia. Training of the team was conducted for almost 4 days, and the 2 teams were trained, and their inter-observer variation and all were calculated, and that because the 2 teams must actually come to the consensus regarding causes and details of entry. So this is a vision testing flowchart where all enumerated people they were examined, and whoever having more than 612 vision, lens was examined, and if less than 612, then pinhole vision, and then assessment of lens, other ocular comorbidities, and if vision is less than 612, which are the barrier why people are not getting their eyes treated. So the results, the study had good response rate 97.6%, and response rate was higher among female 98.3%. There were totally 116 non-responders. Out of that, one was blind due to cataract and others were believed not blind. As far as prevalence of blindness is concerned, we found it to be 2.1%, and severe visual impairment was also 2.1%. When we extrapolated on the entire area, the prevalence was found to be 2.3%, and severe visual impairment found to be 2.3%. The total number of people blind due to all causes in the entire area was 3767, and cataract was responsible for almost 3013 people, that is 80%. Prevalence of blindness was more among female, and prevalence of blindness, severe visual impairment and visual impairment increased gradually as age increased, as is seen in these graphs. Main causes of blindness, obviously cataract was the major cause of blindness, followed by all globe or CNS abnormality, corneal scarring, and corneal scarring again at national level 2015-19 survey also was found to be second most important main cause of blindness. I think it is 7.2% at national level. Cataract surgical complication, phthisis and other posterior segment disease accounted for 3.1%. So also the glaucoma and other diseases. Principal causes in severe visual impairment and MVI categories was also untreated cataract, and that was responsible for 93.3%. As we know, the treatable causes due to blindness were 80%. So we can easily, if we take intervention, we can easily control that kind of part of blindness. So as far as strength and weakness of this RAB survey is concerned, RAB is done in 50 plus population, so less than 50 we don't have data, but extrapolation can help us very well. But strength are like it is cheaper than other like other population based surveys and studies. So we came with the recommendation, clear-cut recommendations, and because ours was the hospital to be started in tribal area where in 100-kilometer radius there was no other eye care facility, so we could come up with the recommendations. We found there is a need to provide effective cataract surgical services in the area as prevalence is very high. Though Gujarat is doing very good in eye care front, but in red zones, which is like bordering areas of Gujarat and Maharashtra, Gujarat and Madhya Pradesh and Rajasthan, the eye care facilities have not reached, and we need to do more in those particularly red zone areas as government have declared. There is a waiting list in the hospital and distance to travel is much more in certain areas. So our hospital was intended to fill that gap. The people in this tribal area are poor. Coming to the hospital would cost them much in the form of lost wages, as Dr. Kansuk rightly said. There are barriers, we need to overcome that. So transportation facility is very much necessary, and eye camps are only way. The awareness is also very important to actually remove the barriers. Females were more blind than males, so we need to educate people in that front. Planning and implementation of Vision 2020 program has also started in our hospital. There is no coordinated efforts in terms of eye care in the area. So careful planning and networking with the public, NGO and private sectors will be helpful. We are running 3 or 4 vision centers. Out of that, one is PPP under PPP model, one is with private hospital. So we are collaborating at different level. increasing human workforce, infrastructure development, and cost-effective disease control are principle of Vision program, and that's why we have started the training program also for paramedics. There is no research or evidence-based ophthalmology practice in state, so we wanted to fill that gap also. So lastly, the conclusion: the prevalence in this tribal area adjoining Gujarat and Maharashtra state of blindness is higher than the national average. Cataract remains the main cause of blindness. Females were affected more than males due to social priority to males in every sphere of activity in the society. Surgical complications are also noted, as we saw in the national survey also. National survey also says that the third largest cause of blindness is surgical complication. So we need to think about that also. High prevalence of blindness and non-availability of the eye care surgical services in the area together imply that there should be a good outreach program and to and fro free transport facility with mechanism to bring cataract blind people to the surgical facility must be planned, along with cataract surgeries with good quality provided totally free or with high subsidy to the tribal populace at the base hospital. Thank you so much for your patience listening. Thank you.
Thank you, Dr. Rohan. So next is Dr. Kamalji Tharjot Madan will tell.
Make some points.
Pardon? No, time. We will. There's no time. Role of NGO in state of Punjab. Dr. Harjot.
Good morning, everyone. First of all, I would like to thank AIOS and Dr. Rustagi sir for giving me opportunity to present on this platform. I shall be presenting role of NGO and private setup in blindness control in Punjab. My colleagues, they are doing lot of good work. So my work has been made easier by the earlier presenters with no financial disclosures. Community eye care is a range of services which help people to assess eye care. It includes eye care programs. These things have been discussed in detail in earlier presentations, so I would like to just summarize. These eye care programs, they offer free eye checkups, spectacles, medicines and surgeries, and they also educate the people, and there is increase in the awareness of eye care services, and also help people with visual impairment, blindness or other disabilities. Screening camps, they are being organized. There are village vision committees, and they also help to encourage people to change their behavior to improve their eye health. Sometimes mass drug distribution programs are also conducted, but these medicines, they are distributed under medical supervision only. And government and NGO programs in India provide eye care services under community eye health programs, rural eye health programs, that is most important. And the program from Sight Savers India aims to provide eye health services to eliminate the avoidable blindness in rural areas. Then we have a national program for control of blindness and visual impairment. Government resources, they work with NGO partners to provide quality eye care services. And government programs in Punjab which provide eye care services are District Blindness Control Society. Implementation of National Program of Control of Blindness takes place through this District Blindness Control Society. So one of the basic human rights is the right to see. We have to ensure that no citizen goes blind needlessly, or being blind does not remain so if by reasonable deployment of skills and resources his sight can be prevented from deterioration, or if already lost it can be restored. So this society, it makes eye care services accessible, especially in the rural and underserved areas. It educates and increases the awareness. It uses government facilities, community participation and NGO. Basically, it's a teamwork. Like Dr. Rohan was saying that there is cross-linking. It monitors the program activities, manages the finances also. The blindness is basically if the best corrected visual acuity is less than 6/60 and low vision is 660 to 618. And the District Blindness Control Society, it helps in preparation of district micro plan based on the magnitude of the blindness and resources available for eye care. And it monitors the program activities, quality control, and looks after the finances also. It increases the social mobilization, public awareness, and it also helps in orientation of various functionaries of health, and other sectors are also involved in this. and procures the good quality refraction sets, drugs, consumables, OT cataract sets, and maintenance of equipment. It helps in arrangement of screening camps, intraocular lenses, spectacles, furniture, generator sets, and also gives financial assistance to eye banks. So cataract blindness is the main, and the society it identifies the cataract patients, lists them in village registers, organizes the screening camps, transport the cataract patients to the base hospitals. Free surgery is done, and the follow-up of these cases is done, and they are also given spectacles. And it also grants free cataract surgeries, and more than 10,000 surgeries are done annually. School eye screening camps are also organized. Like my earlier presenter said that 50% patients they had myopia. So 5 to 7% of the children aged 10 to 15 they have vision problems. Even we should also train the teachers to identify the children with vision problems and refer them to the nearby eye hospital and the spectacles to be given. And free glasses to should be given to children from poor families. 48,000 to 50,000 school children are screened every year, and more than 1,000 free spectacles are distributed to the needy students. And it also trains the health workers, and cross-linking is very important. And village-wise blind registry is maintained through local bodies like panchayats, mahila mandals, and motivation and transportation of the cases through grassroots NGOs, peripheral health staff, link workers, and village communities done. And training is very important in interpersonal communication, and public awareness is done through various media channels. This society also organizes eye donations every year to promote eye donation, and more than 40,000 new cases occur every year, and the common causes include vitamin A deficiency, eye infections, and injuries, and the treatment available is corneal transplant. I have been involved in the community eye services for the last 15 years and doing eye checkup camps. And the people, surgeries, they are done free of cost. In the schools also, we organize the camps, and public awareness is given about the use of mobile and other digital devices. These are the few pictures. We do it annual camps. So this world will not be a good place for any of us to live in unless we make it a good place for all of us to live in. So let's do our bit. Thank you.
Thank you, Dr. Harjot.
Thank you, Dr. Kamalji. Now I invite Dr. Indramohan to sum up that where are we and where more what more is need to be done. Dr. Indramohan, please.
So reaching the unreached basically is a dynamic and evolving process which requires the innovation, and it has to be a system-wide approach at the national level, global level, and of course what we are doing. So imagine, there is a lot of mobile users, but still so many people are not still using. So same scenario applies to health. So many patients or the persons, they are unreached with us. These are the various, unreaching in so many arenas are there, but blindness is one of them, and one of the happy patient is this. So three priorities areas, they need strengthening at the primary level. We need to empower our communities and individuals, and we have to address the socio-economic determinants. So these are basically a spoke wheel. One is health system, communities, and political system. So, and again these three systems are integrated within 5 transformative domains. One is political commitment, multi-stakeholders engagement, and of course these are all data-driven decision-making systems. And again we need to have, from taking data, we need to have health service evaluation, and then we have to have some special approaches. For community engagement to contribute to effective change, we need to go into our efforts. We have to have definite goals, we have to have strategies, and then these strategies have to be there in the policymaker and providers. and then we have to go into the community and build our relationship. So blindness is a significant public health problem, not only in India, globally, and we have a disproportionate in everything. So again, it is a public health problem, and India is basically the blind capital of the world. So China and India, they account for around 50% of the blindness, and more than 1/4 of the person who are productive age, they are visually impaired. So these are the data about the India, and basically thing is the lack of ophthalmologist or the manpower needs the redistribution. So India still, keeping all these things in mind, state of Punjab, Haryana, Gujarat, they have, done significant improvement towards elimination of the blindness. And thing over here, whatsoever is the thing, that is the case finding and the treatment initiation course, that is the basic concept into this. And again, these things, they have some kind of the adverse factors, especially in India, that there is no need felt by the person, lack of person to accompany, and these are the point which I raised in the recently RAB survey. So screening camps in the vision center, they are the most effective vision strategies for identifying and encouraging individuals to take up the corrective eye surgery. With vision centers, they are the most nodal point. And areas of emphasis, that is, we have to improve our eye banking, our corneal transplant services, and of course the cataract surgical practice, especially the cataract success rate also. And all these things, they need to have basically integrate into the refractive services, which are, the RAB survey is already stressed upon. The refractive surgery, refractive errors, that is at the school level. So role of teleophthalmology, already Dr. Dole and other speakers have already emphasized on this, and that has role in screening, consulting, counseling, prioritizing the patient, optimizing the medications, supervision, follow-ups, education, and everything. So that is how Government of India has already, Dr. Hiteshi said, Ayushman Bhav PM Yojana, that is there, and that is doing a great job. But again, at some states, they need to financial restructuring. So it is contributing to overcome the backlog of India. And more, again in this scheme, the more utilization is still there by the male patient. Female are still lagging behind as per the data in India. So again, this is the PMJ spoken wheel again thing, that PMJ beneficiaries, they take the treatment from the eye care facility also, the district hospital also, private setup also, and even tertiary care also. So they are all covered, and affordable and subsidized services, they are free or in charity clinics, again that is covered by the PMJ services. So challenges are there. We need to have access to the service. We need to be aware, and we have to accept it also. Financial barriers, that is being overcome by the PMJ Yojana, but still it is unreachable in some of the areas. Cultural barrier, of course, they are still there, and inequitable distributions of the resources. These are the few challenges in reaching the unreached in India, especially the backlog of the blindness. So to overcome this, we have to have community outreach programs, especially the vision center one, mobile eye care units, vision center. Another point which is there, Dr. Kanshuk has already stressed upon, that is school-based vision screening. That is of utmost importance thing. And of course, awareness camps can be held by the panchayat or the local NGOs, and of course, teleophthalmology is again playing a great role. So strengthening the healthcare, we need to have accessibility, inclusivity, and equity, and of course, all these things has to be given a quality, so that our cataract surgical success rate is improved. So we have to empower communities, and of course, individual level also. And community engagement can be done by the health promotion, participation, and social determinants. So we have to address few socio-economic barriers also. That is, we have to have a poverty reduction also. That is a indirect thing. We have to have access to the resources, And of course, the education, the primary thing. So, and along with this, we have to provide the social protection also. Again, we have to have digital solutions also, telehealth, innovations in the telehealth, mobile health, and data analytics. Everything depends on improvements and what we learn from our data. So, multi-stakeholders, it has to be a collaborative one, it has to be a partnership one, and it has to be a coordinated one. So, all these things when fed into the data, that is we monitor and evaluate, then we do the research on this, and again based on the research we do the interventions. So, it has to be community outreach, awareness campaigns, and accessible eye care services via. Thank you very much. Thank you very much.
Thank you, Dr. Ustugi, for an excellent talk and summing up what needs to be done in the field of community eye care. Thank you.
Thank you all speakers and audience for
Please come
attending
for
the
a
session.
photograph.
Thank you.
Thank you very much.
Over to next session. Sir, thank you. Ma'am, please look.